Hello, everyone. We are now going to go over the bone marrow flow cytometry plots from a 5-year-old male who presents with leukocytosis in the range of 100,000 cells per cubic liter. When we start with CD45 versus side scatter, we see that a large number of cells, which are painted blue here, express dim CD45 and low side scatter, which are in the blast gate. There are few cells in the lymphocyte gate and few cells in the granulocyte gate. Now, when we follow through these blasts, they express bright CD19, as we see in the B lineage blast, and they are negative for CD20. We can compare the background B cells, which express bright CD20. Our blasts express dim CD45 and are negative for CD20. They have bright CD10, again, like B lymphoblasts. They have CD38 positivity. They form a tight cluster in CD58, which helps differentiate between hematogones and neoplastic blasts. Neoplastic blasts form a tight cluster, whereas hematogones are more heterogeneously positive for CD58 and CD9. So here it is more like neoplastic blasts. And again, this is just repetitive that it is 19 and 10 positive, 58 positive, negative for 20, 38 positive, and 10 positive. Now, in the next tube, we see that the CD19 positive blasts also form a tight cluster with CD9. They are positive for 1333. They are positive for CD34. And again, they're positive for CD10. Now, this is another additional tube. The interesting thing about this tube is that this one does not have CD19. So almost always when we gate for B cells, we use CD19 to gate for B cells because CD19 is consistently expressed through all stages of maturation, right from the B lymphoblast stage or the progenitor stage through the mature B cell stage. So we always use CD19 to gate the B cells. However, in the recent days, we have therapies for blasts that express CD19. We have blinatumomab, which is an anti-CD19 a BiTE reagent, and we have CAR T cells for CD19. So there is a chance that when these cases relapse, or when you're evaluating for minimal residual disease, we can have B lymphoblasts that are negative for CD19 because of therapy. So to make sure that we don't lose, we don't miss those blasts, we use other combination of markers to identify the B lymphoblasts. Here we have CD22, CD24, and CD66B for that purpose. So CD22 is positive on B lymphoblasts and hematogones and B cells. So we get the cells that express dim to positive CD22. So CD24 is another marker that can be positive on both B cells, B blasts, hematogones, and granulocytes. So we have these populations here that are positive for so we know that our blasts are B lineage blasts, right? So we have B lymphoblasts that are positive for CD24, and we have granulocytes here that are also positive for CD24. The role of CD66B is to eliminate the granulocytes from this gate because granulocytes express both CD24 and CD66B, so they sit here, whereas lymphoblasts are negative for CD66B, so they will sit here. So that's how you will isolate B lymphoblasts without using CD19 by using CD22, 24, and CD66B. So when we see this, those blasts are negative for CD20, and we see our mature B cells here. In contrast, CD24 is positive on the blast, CD38 is partial, 10 is positive, pretty much everything else is the same. The reason that I'm showing this plots is just to show you an alternate way of gating, that most labs have these tubes already set up in the first diagnostic specimen so that they have the full phenotype which they can use to compare for evaluating minimal residual disease. The other thing interesting in this case is that we have the CRLF2 graph. So in this graph, the red is the control population, and the green are the blasts, and the x-axis is the CRLF2 protein expression. We see a high CRLF2 expression by the blasts in this case. So what is CRLF2? So in the recent years, WHO has added a new category of BALL under recurrent genetic abnormalities, which is BALL with BCR-ABL-like translocation. So these cases do not have BCR-ABL translocation, but they have their genetic profile similar to the cases with BCR-ABL translocation. So almost half of these cases that are BCR-ABL-like have the CRLF2 translocation. So this is used to identify those cases that have CRLF2 translocation, because they found that almost all cases that have the translocation express the protein, and that can be picked up by flow. Flow is very sensitive to pick up CRLF2 expression. So what is the clinical utility of this? One, they think CRLF2 expression is associated with poor prognosis, although there are conflicting data on that, where some state that it is only on a certain patient population. We don't know yet. The other thing is, half of the patients with CRLF2 translocation have JAK mutations. So if we see CRLF2 expression by flow, the clinicians can order fish for CRLF2 if they want, and they can order the JAK mutation studies. And if that is positive, they can add on the treatment for JAK inhibitors, especially ruxolitinib. And they often see that these patients are resistant to conventional chemotherapy, and adding these alternate tyrosine kinase inhibitors are helpful in treating these patients. So that's the importance of CRLF2. And most facilities do this analysis mainly for pediatric population, because it seems like when as the age increases, the incidence of CRLF2 translocation decreases. So for this case, it is a BALL, and we'll give the percentage of blast. And in the description of our blast phenotype, we'll say that CRLF2 is positive. Thank you.